Okay, so I want to start by saying I know that anybody on here who's mental health has done a lot of training, seen a lot of trainings on how to assess for suicide. I think in the last 10 years, there's been a very needed and appropriate focus on that. So we're hoping to make this not just that because it'll be redundant information. I really want to focus more on what you can expect when a kid comes to the ER. I've been doing this for a long time, so I should be able to address most of that and just really focus on the actual role of an ER in doing those mental health assessments. I sometimes can tell by both families and kids who are referred by providers that come to the ED that it's not always exactly what they expect. And partly why Tricia has joined is because we do have our Behavioral Health and Wellness Center. Um, all very excited for that to open next year. So some of what I'm covering will grow and change as the Wellness Center opens. All right. No disclosures. I shouldn't have any conflicts here. Um, Talking about the social work role. So these are obviously specific to Children's Hospital. I think it's fairly similar in a lot of ERs that deal with mental health. They don't always have mental health providers in probably some of the smaller communities and stuff. But um, social work role is here at Children's, most of our social work providers are master's level staff, which means we are also licensed mental health providers. So and once you have a certain number of hours done, like myself and several of my colleagues are independent mental health providers, which means we can also diagnose and work outside of the coverage of like a psychologist or a psychiatrist. So the first thing I want to say about the social work role in dealing with suicide ideation or kids that come is it's not about predicting. Sadly, if suicide was predictable, it would never happen. Those persons would be stopped every single time. And I wish that was the case. Um, but what it is about is planning to manage the risk. So people are coming into us, kids are coming into us in some level of mental health crises, and our role is to assess the risk that they're up against and what does that patient need to maintain that risk. It might be hospitalization, it might be returning home with resources, support, and safety planning. Um, we also play a big role in supporting parents because we're a pediatric hospital. We're only assessing kids up to the age of 19. Um, we play a very big role in educating, supporting, and providing resources to the parents when the kids come in. And then we handle once it is determined that a kid need an additional part of our role here at Children's is handling that transfer. I do want to say that ultimately although the mental health practitioners play a very big role in managing and assessing this risk and making plans, we are also just aware that this is ultimately the physician's patient. And they feel very responsible for the liability of assessing this risk. So we work very closely as a team. And in the rare circumstance where we would disagree with the outcome or the recommendation, we might seek guidance by a member of the behavioral health team, a on-call psychologist or psychiatrist. But ultimately, the ED attending would have the final say with that patient and what happens with them. All right, I want to talk a little bit about depression versus suicide because this is some of what we're coming up against when we're assessing the risk. Um, there's obviously, we could all guess that there's a strong correlation between depression and suicide. Most common that a person who attempts suicide has some level of history with depression. It could be more diagnosable and chronic depression. It could be more situational depression. Um, not every person who is depressed is suicidal. Obviously, depression is one of the risk factors that we're looking at, but not every person who attempts suicide is depressed either. So, as a therapist or as a school counselor or any helping professional that's dealing with kids, you don't, you're not always looking at the same thing to a kid who's really stressed out and depressed and dealing with things versus suicide. An example of a risk factor that doesn't guarantee admission, either eligibility or need, is self-harming behavior. Um, there's a lot of kids nowadays that we see who do the cutting, and we see kids with really bad cut marks, scars up and down their arms, sometimes on their thighs. Inner thighs is a common area, but we also see kids who use self-harm as a release valve. I had a kid last night who told me when he cuts, it's like a pressure relief. It's a pressure relief valve for him. Other kids are showing signs of anger. They're giving voice to their feelings that they don't know how to get out. It's a form of distraction for them. Is it something we approve of or want or encourage? Never. Is it something we want kids to learn different coping skills? Yes. But I also think it's important to note that they don't always get referred to the ED. You can stay on this screen for a sec, Paige. Here's a list of what we see as pretty typical clear need for hospitalization. Kids that come in, it's very likely they're going to go from RED to an inpatient psychiatric unit. One of them is a potentially lethal attempt. The most common forms we see of these is going to be kids who try to hang themselves. Hanging is a very scary, potentially lethal attempt to die. And overdose, but it's the kids who overdose on so many meds that they end up in the ICU. It's the type of medication that they're overdosing on, and how much is their level of understanding of whether or not it was lethal. We're going to look at a planned out attempt. How long is the history of their ideation? Has it been going on for a long time? Kids who have multiple previous attempts. So this one can get kind of tricky. It can be a little bit of a gray area because there's some kids who have had so many admissions to the hospital that the inpatient units stop accepting them. They say that it's not a level of care that is effective for that child anymore. And that makes it really difficult to ensure safety and make sure that they're at the right level of care. Kids who report feeling, they get to RER, they've said something to one of their friends or to a school counselor or a therapist or whatever, maybe a parent. They get to RED and continue to report those feelings of being unsafe, that they don't trust themselves to go home. It's also eligible if a parent is reporting feeling unsafe having their kid at home. So sometimes we can really push for an admission to the hospital, even though the kid falls in a bit of a gray area, or we have a child who is reporting that they feel safe themselves, like they're not going to do anything, but the parents are saying, no, 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 we don't feel safe. We don't think we can keep this kid safe. You can really push for inpatient admission when that happens. Self-harm behavior without any ability to express what's going on, what their intentions or feelings are behind that self-harm. And lastly, a kid who is saying, yeah, I want to be in the hospital. I feel like I need to be in a hospital. We're usually going to try with those kids unless there's really a specific history. I want to say a little bit about what we consider lethal, or what we would consider at least a lethal attempt. One is that the kid took all the medications available to them. Maybe it wasn't something that was going to actually kill the child, but it was everything they could find. So there was no discretion on the kid's part about how many pills they were going to swallow. If they don't tell anyone, we have lots of kids who swallow meds and immediately make themselves throw up or go and tell somebody, tell a friend, send a text, go wake up a parent. So if they head to bed and don't tell anybody and they're really not sure if they're going to wake up the next day, we would consider that higher risk and scarier. Um, kids who don't lack kids who lack the maturity level to know that their attempt was benign, but they still wanted to die. So this might be a kid who takes 10 ibuprofen, and as medical staff, we know that that's not going to cause a whole lot of physical medical risk, but that child didn't know that. He took those 10 pills, he went to bed, didn't tell anybody, um, had no idea if he was going to wake up the next day. We would consider that a lethal attempt, even though it wasn't something that was going to cause death. All right. These are the harder ones. I want to talk through a few of the shades of gray that we see when we're evaluating a case. Um, you want to look at the facts of the case. Sometimes it can get easy to get into, to start to ignore the facts because of a sympathetic interview. Um, an example I can give you of this happened a number of years ago for me. It was a younger child who uh, attempted to hang himself in the shower using the shower rod kind of thing, the ones that are detachable, and actually passed out in the shower, and his mom found him. And for some reason, that child um, came from a good family, presented really well, kind of said all the right things to me. And I was leaning more towards just letting him go home because that's what he wanted to do. And with some advice from the team and seeking some of that out, realized that I was forgetting to look at the facts of the case, which is this child made a pretty serious attempt to die and probably could have in different circumstances. Um, Another shade of gray would be a non-life threatening attempt that we talked about a little bit. So you kind of need to see what that was all about and how planned was it. Um, Sometimes it can be a gray area if there's minimal to no medical intervention needed. Um, may Example I wrote down is I had a 9-year-old who was upset, like mad at a parent or whatever, and tried to hang herself with a grocery bag in the back seat of the car, and she was brought to the ER. Well, obviously that's a very impulsive attempt. The kid was kind of tantruming. It didn't require any medical intervention, so those can be kind of tricky, figuring out whether or not they meet eligibility for admission and would an admission be helpful or effective for them. Um, Sometimes the gray areas come because there's really no mental health history with the child. One of the things we're going to look at is, have they been engaged in mental health services? Do they have anything set up now? Is it going to be a long time before they're able to get matched with services, either because of availability or where they live or insurance or parents' motivation and intentions of doing that? Um, Very young children can be gray, partly because you worry about the impact and potential trauma. That's a strong word to use, but could be potential trauma of that child going to an inpatient unit with high acuity kids who are older than them. These inpatient units, they have to be separated from their parents. Parents cannot stay at any of them with the kid. They're children only treatment. Parents have visitation. Um, so yeah, you really have to look at those. Most facilities, I've had kids accepted as young as 6. That would be really young. Most of them won't take much below 7 or 8, I would say. You can certainly let me know if you hear differently. Um, some of the things that we look at with these gray areas is, um, these are also just areas that get us into Are we going to admit or are we not going to admit? One is the kid, there's circumstances enough to recommend inpatient, but the child is now denying any intent that, yeah, I said these things. Yeah, I wrote a note or a text, but I'm safe now and I didn't mean any of it. Um, when we run into parents who don't support the plan for hospitalization, and we'll talk about that a little more in a bit. Um, Patient retracts their statements. I talked about that. Uh, and at-risk patients, but they have no history of mental health intervention. And so it's kind of like they might be safe at a lower level of care, but right now there is nothing available to them, nothing set up. So we're sending them home with no expectation that they're going to see a therapist within the next few days or weeks. All right. These are just some additional risk factors that we look at. So when we're stuck with some of these gray area cases, it's not going to be an easy admission or an obvious admission. We're going to look at a whole list of things. How many previous attempts has there been? What's the history of depression, alcohol and drug use? Um, what level of hopelessness is the child asking about? I always ask about hopelessness. How much access, what is their level of access to lethal methods? Do you have parents? Parents can play a big role in some of these um, that understand, and I want to use the words buy into the risk of mental health. So, do you feel like parents are going to go home and lock up medications or take our recommendation for removing guns from the home if they are gun owners? Um, are they going to keep the child very, there are times, it doesn't happen a lot, but we will send a child home with an expectation that they have eyesight supervision until they see their therapist, who they're already matched with. And by eyesight supervision, we mean sleeping in the same room with the parent, having an agreement with the school, or keeping the child home from school, even preferably. And we would only do that where we're expecting that for a day or two. But it's not keep an eye out, check in more than you want. It's they are in the same room with you and you have eyes laid on them day and night until they have a different assessment brought to them. That's usually done when we have a parent who uh, is really against the hospitalization and we're trying to come to a compromise in the middle. All right, a few other risk factors. Click one more for me, Paige. These are kids who are a little more things we would look for kids who are a little more chronic with their mental health. Um, PTSD, prior traumas, kids that are dealing with borderline personality disorder, BPD, maybe in treatment, maybe not. Significant behavior disorders, those are ones that can be really difficult for, they can be difficult to place, one, and they can also be difficult for parents to just get the help that they feel like they need. Um, it doesn't happen a lot, but I definitely run into parents who just do not seem to be taking the situation seriously. There are, might surprise some of you to know that there's a lot of parents who bring their child to the ER solely because they are instructed to, either by their primary physician, a counselor at school, um, maybe a CPS worker if they're involved, but some person that's has some level of authority with the family or with that child has instructed the parents to come to the ER and told them that they will be filing a report potentially if they don't follow through with that. So those parents will come, but they just don't have a lot of buy-in about it. They don't think the kid's at risk. They're not worried about their child hurting themselves, even if we are. And so some of those parents are not able to maintain safety or won't follow up with the outpatient expectations. And some parents that are just not capable of doing that, even if they do want the help and they have the buy-in, they don't have the cognitive ability to understand some of that and figure out what they need. That last comment on there about consider the risk state versus risk status, we're talking a little more here about chronic mental health issues. Suicide ideation, sadly, can be the baseline for some kids. Like that's just a heavy blanket they carry around all the time. They have these obsessive thoughts in their head, but it doesn't match plan or intent. It's just something they're carrying around. So most of those kids have had at least one, if not multiple, inpatient admissions. They're usually in treatment. But it's not that inpatient is necessarily going to be a match for them. Versus risk status, and that's where we're comparing the situation to others. So suicide ideation can be considered very out of the norm and scary for another child who has never had those thoughts before. So you can kind of see where we're going to weigh out those different factors and how much it plays into the services that are available to us. This is some of our symptom risk factors. These are questions that we're usually asking each of our patients in our assessment. What are they considering their level of hopelessness, desperation? Do they feel like they're a disappointment to their parents? What are we looking at in terms of their own sense of self-worth? Often talk about social relationships. We see a lot of kids that are dealing with a lot of bullying type behavior. And within the past year, I feel like more and more we have had to add social media type questions to our assessment. How heavy is their gaming addiction? How much are they relying on AI now? How much are they talking to ChatGPT? The hard part about these is I find very few kids that are very honest with us about that. I had a child last night that has a significant online problem with the scary things that he is looking up and dealing with online, trying to access online, and he denied all of it. I never would have known any of it if the parent hadn't already confiscated some of that. And also, including myself, parents can be very oblivious to some of this stuff that's going on. They think they're watching their kid, they think they're managing their websites, and they are accessing things that we would never imagine, even on school devices that don't seem to have some of the barriers they should. And lastly, I ask pretty much every patient to just give me a number from 0 to 10 in regard to their suicide intent at that moment. When they, either right when they came into the ED, during the day when they were at their worst point, but it has to be acute, if that makes sense. So I'm not asking for 0 to 10 over the last year. But I will have kids who say, well, I feel better now after talking. You know, that they come in, they talk with us, they talk with the attending. Maybe just before that, they talk to a school counselor. They feel like their secret's out. So it's a big sigh of relief. And the kid's like, yeah, I feel better. I'm only a 1 or a 2 on my intent. But if you look at the facts versus what were a sympathetic interview, we know that that child has not received any treatment. They're feeling better. They've started to manage some of those, but their suicide risk remains high. So we try to get the kids to look at over the course of the day or over the course of the last couple of days, where would you be on a 0 to 10? And they're usually, it's pretty revealing. It's a good thing to ask. These, I just listed some behavioral warning signs that you might look for, reasons to for sure be concerned, send a kid to the ER. We don't always know about these stuff, but a lot of times they are found once you have a concern and parents start really looking through their kids' phones or bedrooms, stuff like that. They're finding things they weren't expecting. Um, all right. I want to talk specifically, those are all some of the gray areas, the warning signs, things we look for in the ED. Some specific things about when to refer. This is kind of hard, and Paige and I even had some discussion back and forth when we were doing this presentation because it's I feel like it's a very subjective and personal decision to refer, especially if it's a client or a patient of yours, to the ED. Because not everybody has the same comfort level in talking about these things and assessing the risk. Maybe it's something that they've never dealt with and they don't want to be making those decisions alone. And no one would ever be turned away. So I start with that. When in doubt, send them to the ED so that we can help. It can also be dependent on time constraints. You know, you're running a clinic, you have patients all day long, hour after hour, and you don't have the time to sit. Most of our evaluations in the ER, just with social work intervention alone, you're looking at 2 to 3 hours of talking with the patient, talking with parents, getting those things written up. So you don't always have time for that in your other jobs. I will also say it's rarely, if ever, does harm to have a kid come to the ED and be evaluated, because even if we're not able to get them what the person referring was hoping for or what the patient or parent is thinking is going to happen, it can bring a lot of comfort to the family. And I wanted to read, I got a reply just this week actually from someone of a daughter who had visited the ER, and this was last fall. So it's been almost a year since she's been here. And the mom said, to this day, several months later, she will occasionally mention how nice the therapist was in the ER and how it made her feel like she had someone in her corner on one of her hardest days. Mental health concerns are not always met with understanding and grace, but I feel like this person went above and beyond that day to understand what was happening in my daughter's world and provide her with words of encouragement and hope. As a parent, I cannot thank you enough for the grace and warmth you showed my daughter and to me as well. So I thought that was just really heartwarming and shows how much of a difference an ER visit can make, even if we're not getting you exactly what you had hoped for. I have a few more of referring to the ED. Sometimes kids are sent here due to high PHQ screens. Most of the time, we would want that high depression screen to come with an intent of harm to themselves or others, other than just a high screen, which suggests a myriad of things. It shows a risk for depression and maybe a need for further evaluation, but not necessarily anything that would suggest ER. Like we talked about, parents reporting that they don't feel capable of keeping their child safe during a mental health crisis. Usually, if you're looking at some level of psychosis, hallucinations, delusions, severe paranoia, for whatever reason, the child is not at their baseline and maybe nobody knows why. That would be a very appropriate ER referral because we're able to rule out both medical reasons. We can run the labs, we can see if they ingested something that's making them act this way, or is it truly early psychosis? And that is another form of hospital eligibility for inpatient psychiatric admission, would be kids who are showing signs of psychosis. Any level of overdose, hanging, suffocation, any kind of self-injury that requires medical care. That seems like a pretty obvious send. And sometimes it's already been determined by that child's psychiatrist, especially, that they want an inpatient admission, but they need help with labs and the transfer process. So there, they still have to go through the process of being evaluated by the ER, but I would encourage them to handle to communicate. I would encourage them to give a handoff to us so that we can do the labs, do everything we need to do, but have the intention of moving towards an admission. All right. Things that I think are important to know, and I know not everybody realizes when they are sending a child referred to the ER. We do not have a psychiatrist. And ED, we have psychiatrists that work for children's, but not that work in the ER. And our ED attendings will very rarely prescribe psych meds. They are not comfortable doing it. They don't have the ongoing ability to maintain those meds. It's not like a antibiotic. You get them a script, you're going to take this for 2 weeks and you're done. Especially if they're not sure that the kid's going to have follow-up services. So parents who are coming here or providers who are sending their kid here with thinking that they'll get a evaluation and get started on meds, it's not going to happen, not through an ER. So there should be bigger reasons that you're sending them. If that's something you want, they should be set up with outpatient services. Find the best and fastest referral you can get. There is never a guarantee of admission, especially to Boys Town. Boys Town can be pretty selective of the kids that they will take, even if they are being referred to us by a Boys Town therapist, a Boys Town psychiatrist. Gosh, even kids who live on their campus, they're getting a little better about that, but that does not guarantee an admission to their inpatient psychiatric unit. And we have lots of families that will be referred or come to children's ER because they want to get an admission to Boys Town. Boys Town doesn't have their own emergency room, so they have to come here to get medically cleared, but it doesn't guarantee. I also think it's important to understand that parents very much have a voice in all of this, but they do not always have a choice. So if you come to an ER and then really change your mind as a parent and feel strongly about not getting admitted, there's no guarantee that you'll have that ability to back out if we're worried enough about your kid. I think the time factor is an important thing to note for families to be told or to understand. This isn't something that you're going to come to the ER and be done in 45 minutes. You're always looking at several hours, if not several days, where they get stuck waiting in an ER, waiting for a bed. Patients do not receive mental health treatment while waiting in children's ER. They will be kept safe. They will receive therapeutic and trauma-informed care. They will be kept supervised 24/7, one-on-one safety attendant. But they're not here. They're not going to receive treatment. They're not going to go to group meetings. They're not going to get one-on-one therapy. They're not going to get a psychiatric evaluation. They're here for a risk assessment, not for mental health treatment. So I think that's important to understand because a lot of people that come are disappointed when they are figuring some of that out. We can click through some of these pretty quickly. It's just more of the same. We're going to recommend hospitalization pretty much anytime there's been an actual suicide attempt. The default is generally to go inpatient as opposed to home. And then, like we talked about, the hopelessness, didn't tell anyone, past attempts, that kind of thing. The considerations for sending home are going to be things that sound a little more impulsive. The kid was mad. It's more behavioral. They told someone immediately. They already have a team of people that are helping them. Strong family investment to the kids' mental health, parent buy-in, all of those things are going to be considerations for safely sending them home as opposed to hospitalization. And then the gray areas that we talked about, where some of these we're going to seek help, we're going to ask other people. Sometimes when in doubt, try, see if we can find them a bed. This next slide is a little bit about protective factors. A lot of it is about their team and being connected to who can help them. Just a quick slide on what a safety plan might include. You can always reach out to us if anyone is looking for more information or training on how to do a solid safety plan, if you wanted to do that from your own areas. I think I covered up all of that. I always, if I'm sending a kid home, I want that child prepared for any expectations in going home. I don't want there to be any surprises. So myself as the therapist, the family, the guardians, whoever, and the kid are going to meet together and say, okay, when you go home, this is what's going to happen over the next few days, so that they don't get home and get all upset of not expecting something. All right. That I think we're good. It's just kind of what happens when a kid comes to the ER. They get triaged, they go into a room, they usually meet with a resident if a resident has signed up for them, or the attending before it gets handed off to social work. And then social work is going to meet individually, both with the patient and then with the parents. We're going to collaborate with the physician, make sure we're all on the same page, and then we're going to handle the discharge planning. All right. I want to spend a few minutes talking about caring contacts, and then I'll hand it over to Tricia for a bit. Caring contacts at Children's is something that we've been doing. When did we start this, Tricia? 2015 or 2020 we started with the student project. So to me, it came to me through a magazine article that my boss at the time had brought to me, and we were seeing such a significant increase in suicidal ideation and suicide behavior, like literally doubled from 28 to 2015. And that's when social work started to become more and more needed in the ER, to the point of getting a full-time social worker. And now we're down there 24/7 because there's mental health needs all night long. It doesn't stop. And so it's difficult to cover that just with on-call. Okay, so we had our first introduction to Child Connect through a student project that started looking into it and getting connected to Zero Suicide Framework. So this is kind of what they are. They are basically any youth who comes through to receive a clinical interview or an assessment from us. As long as parents approve with just a release of information, they're going to get enrolled in the Caring Contact program. They are handwritten. I tell the kids snail mail cards that they're going to get over the course of a year. So within 2 weeks to a month after their first scene, they'll get their first card, and then they get them at 1 month, 2 month, 3 month, and then 3 month intervals after that. So 6 cards over the course of a year, all handwritten, decorated with stickers and little nuggets that we put in the envelope. This is just some of the essential components of it. Tricia did a lot of work on making this duplicatable, copyable. What's the word I want?
Replication, a replication.
Yes, replicable. So we really, one of the things in terms of like it says, stick to the script, no pressure, that kind of thing. We are not trying to form a therapeutic, so to speak, relationship with these kids. We were very conscious of the boundary aspect. So it's always going to be the person who did their interview, as long as we're capable of doing that fits with their job. They're going to be the ones that reach out to them over the course of a year. And they're just scripted little notes to the patient that lets them know, hey, we remember you, we're thinking about you. Mental health is lifelong. This wasn't a one-time deal you've forgotten. You've forgotten about it, we've forgotten about you, and you go about your life. This reminds them that they're going to keep working on that throughout the year, and that they have someone in their corner that's cheering them on while they do that. Some of the rewards that we're seeing, it has been such a much more impactful program than I ever would have guessed when we started it. Like I would pretty much bet that every social worker that has done this for any length of time here at our hospital has 110% buy-in to the importance of it. It reduces recidivism. It increases youth and parent awareness of the importance of staying engaged in mental health services. Uh, I think it does help with the burnout rate for staff because of some of the positive impacts of it, and increases prevention for anyone completing suicide. And then we have a couple of little just nuggets of some of the replies. The kids are never, there's never an expectation or requirement for them to reply, but they are given that option just with the return address on the envelope, and it'll find its way back to the social worker. You can see in the middle of this, when I was seen, I thought the only way out was that permanent solution. I want you to know I'm insanely grateful for you cheering me on, and I have gotten so much better since then. Bad days and bad things happen all the time still, but I know how it's not forever, and there are so many other solutions aside from suicide. So that's beautiful. Here's another one saying, I always meant to write back. I wanted to let you know how much of an impact the cards have had. To know someone I met once cares so deeply for me. I am doing the best I have been since a year ago. I never imagined this much happiness was waiting for me. Been hard times, but I've been able to overcome them. So it's just over 5,800 cards that we've mailed. I've had one or two in 10 years, parents who have said no for whatever reason to engaging. So close to 100% of the parents choose to enroll. 15% have a repeat suicide behavior compared to 30 to 60 youth recidivism rates nationally. 78 patients and 9 family members have responded. It's probably even more than that if I had to guess. And best of all, 0 suicide. There are no patient deaths of enrolled patients reported to date since the program began. And not that that's the only reason that it's being stopped, but it's still very exciting. So that's our caring contacts. And Trisha, I'm gonna let you talk about a very exciting thing happening in January 2026.
Hey, I will add one thing about caring contacts for anybody that is interested, especially if you're from an organization external to children's. We, as Shanna mentioned, did work on a replication kit that I can send you. You can reach out to me. We can have a meeting about it if you want to implement the program in your organization. I don't know if my contact information. I don't know if I put it in the chat, but you can always reach out to Paige, and she can get a hold of me, and I can talk to you about caring contacts. But what I am here to talk about is our new Behavioral Health and Wellness Center that is opening in January 2026. So new and very exciting things happening here at Children. If you drive by here, you can see the building is just very underway. They actually put the sign up the other day that says Children's Nebraska Behavioral Health and Wellness Center. So lots of great things. Our team is actually starting in just a month. So we're hiring about 160 team members, and they will get like 10 or 11 weeks of training before we open our doors on January 7th. So we will be hopefully a very well-oiled, well-trained team by then. Things to know just in general about the center. So we will be a no wrong door approach. So we will take any and every patient, regardless of anything that they have going on with their mental health. So if they're involved in the juvenile justice system, if they're state wards, some organizations, as Shanna mentioned, won't take kids who have diabetic care needs, maybe not comorbidities with substance use. No one will be turned away from our doors. Except, and we will still take them in, but adults. So we won't treat adults here. We'll bring them into the urgent care and kind of meet any maybe immediate need that they might have, but they will be referred on to adult services. We will also be very trauma informed here. Our entire staff will be trained in trauma informed care, in the way that we deal with patients, the way that we deal with families, and the way that we deal with each other as team members will be trauma informed. So we will have every level, well, except for, as I shouldn't say residential, we will have almost every level of care that is needed in our buildings. So the areas that already exist in the community that will move into our building is a primary care office. So we will have a children's physician's primary care office in our building. And then outpatient behavioral health that already exists, children's outpatient behavioral health, will also move into our building. And then we do currently already have an eating disorders partial program that will move into our building and pretty much stay the same, except for that they will take on a few more patients than they currently take on. But then we will have 3 new levels of care. So very similar to what the emergency department already provides, and what Shanna explained to you is our crisis assessment center. What is unique about that model is there's 2 parts to our crisis assessment center. There's the urgent care, which will function similarly to an emergency department, where a family can be brought in. Our goal is for them to very quickly be met by a team member, not to have people in our waiting room. So they'll be quickly met by a nurse or a therapist and be brought in for an assessment. They'll get a very quick medical once over by a nurse to make sure there's not medical needs that need to be met, and then an assessment by a therapist. And if things can be addressed right then, it looks like maybe we can provide them some quick interventions, some resources, and some safety planning, and they can return back to the community. That is what will be done. If it's looking like that's not going to be the case, and they might need a little more than just that quick assessment, intervention, and resource, the other part to crisis assessment is our crisis stabilization unit. This is a very unique model. This will be where a patient can stay up to 23 hours and 59 minutes in a non-medical type setting. So it will not be like in an emergency department where you have a medical bed. They will be recliners, and they will be in a group setting. So patients will not be by themselves in rooms. They will all be together in recliners, stabilizing together as much as possible. Studies have shown that this is the best approach to stabilization. There will be individual areas where they can stabilize if it's needed, maybe because they're detoxing or they're having some escalation where they do need to be alone. But by and large, we want them to all be together. And they can stay there, and we can continue to hopefully work on a discharge plan for them up until they've met that 24-hour mark. And if we can't come to a safe way for them to return back to the community, then they will be referred on to a higher level of care. Some differences about the crisis assessment center and the emergency department is the staffing model. So our staffing model here will be a psychiatrist, a psychiatric APRN, a nurse, a therapist, a behavioral health tech, a peer support specialist, and a behavioral health navigator, which is like helps to navigate resources in the community. So that whole team will work with the patients. And so as Shanna mentioned, that they in the ED, they don't get treatment. They will get treatment in the crisis assessment center while they are stabilizing. Our therapists will provide them with interventions and therapeutic so basically, maybe the best way to explain this is that we will actually have a schedule of daily events that will be followed as much as possible. So patients will be scheduled to do group, individual, and some family therapy. That might not always be able to happen because of the crisis that they might be in, but whenever possible, they will be getting therapeutic interventions while they are in the crisis assessment center. And so that is probably one of the key differences as what a medical emergency department can provide to a patient. The higher levels of care that they'll have is our inpatient unit. So our inpatient unit will be 40 beds when it's at its maximum capacity with 8 patients on each unit. It is staffed in the same way that the Crisis Assessment Center is staffed, with those same team members wrapping around the patient. And the goal for the length of stay, as it says on there, is about a 5 to 7 day length of stay. And then they will do those same inpatient group and family type therapies. And then our other brand new program is mental health partial. That program will be for patients that come to do treatment during the day, but then are able to go home at night and return the next day. On average, that will be about a 5-week program with step down into intensive outpatient when the patient qualifies for that. So one thing to maybe just keep in mind when you're sending patients here, and we will ultimately figure out if a patient shows up at the wrong place, we will figure that out for ourselves. But if you have a patient in your care that will need medical attention, the best place for them to go will still be our emergency department, because we won't be able to manage many medical needs in our new center. Maybe some superficial cutting or something like that we will be able to, but if the patient has ingested some sort of medication or they need a medical intervention, the emergency department is the best place for them to go. But like I said, if they come here, they're supposed to be in the emergency department, we are going to make that happen. If they go to the emergency department and the need is strictly like behavioral and mental health without any medical attention, we will make sure that they get over to the Crisis Assessment Center. Another thing to mention, so all of our staff will be trained in a de-escalation approach that includes both verbal de-escalation and physical restraint when needed. So everyone will be trained with that. We just have lots of really cool and amazing things. We'll have sensory rooms, and we'll have quiet and comfort rooms. We'll have lots of different places for patients to be able to be to meet their unique needs for the time that they're here. I think I mentioned it will open on January 7th is when our grand opening is. So that is officially when you will be able to start sending patients our way. And all of these areas will, the ones that already exist will continue to function in the community until then, and then move over right before opening. But everyone will be here under one roof starting on January 7th. And I think that pretty much covers it.
Awesome. Thank you, Tricia. I'm so excited. Paige, are we missing anything in terms of questions before we log off, or are we good?
We didn't get any questions in the Q&A. So if you have questions, you can go ahead and type them in. My contact information is in the chat, as well as Tricia's, for information about Caring Context. But if something comes up later that you have a question on, you are always welcome to reach out. If you have a patient or a client who comes to you and you want more kind of in-depth assistance, COPE's provider line is available for you to use as well. I've talked with people, I've talked them through how do you assess for suicidal risk kind of in the moment. So if that's something that comes up, we're available as a resource to you as well.
Cool.
But I'm not seeing anything come through in the chat. So I guess we can give it another couple of minutes. But if you don't have any questions, you are free to hop off. I think we are done for the day. Next month for October, our topic will be autism evaluations. So if that interests you, please join us next month.